1 second. Okay. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good day today. I forgot Victor's English. This is Dr. John Bennett broadcasting from Miami Beach, home of Neurosurgical TV. Today, we have another webcast. The name of this group is now Neurosurgery Aspirants, which basically means that there's students and medical students that want to go into neurosurgery. And we try to present broadcast, kind of a broad spectrum of broadcast. And our first speaker is a gentleman I've known for a while, Victor Hugo Perez. He's probably one of the most well-known neuroanatomists in the world, thanks to this platform of Zoom, Victor. Okay, Victor, it's all yours. Once you
Thank
start.
you so much, John Bennett. Thank you. It's a honor for me to be here. Let me share my screen. Now, is this okay?
Perfect.
Okay. Thank you. So, thank you so much for this kind of honored invitation, John Bennett and dear colleagues. So I know that this lecture is for neurosurgery aspirants. So what I want to tell them is first to think in neuroanatomy. Neuroanatomy is the best way to understand every kind of okay. Let me see what's happening with my presentation. Okay, I think I have a problem, John Bennett. Okay, I think I have a problem. So, is it possible to go to the next speaker, please?
Yeah, okay.
I have a problem.
No problem.
Okay.
Take your time, Victor.
Okay.
Okay, I'd like to introduce Dr. Khan. Dr. Khan, are you there?
Yeah, I'm there.
This is a little switch, but we'll adapt. Dr. Khan is a pathologist, and she agreed to do a neuropathology for this lecture, and we appreciate that. And thank you, Dr. Khan. It's all yours.
Thank you so much. It's my pleasure to present it. So I'll share my screen. Can you see my screen now? Can you see my screen?
Yes, Dr. Khan, we can.
Okay. So, good evening, everyone. My topic for today is cerebrovascular diseases and CNS trauma. Uh, this is the second lecture of my. Can you please give me 2 minutes?
Yeah, it's fine.
Yeah, it's prayer calling. So,
You okay, Dr. Khan?
yeah, I'm fine. Actually, there was a prayer going on, and it's quite loud. So I thought maybe there'll be some disturbance in the. Is it okay?
Yes,
I'm
perfect.
audible.
Perfect.
Okay. So we'll study and we'll understand the classification and causes of cerebrovascular diseases, and we'll see how to differentiate between the ischemic and hemorrhagic strokes. And we'll also understand the pathophysiology and morphology of the brain infarcts, how and what we see in the microscope and in the gross brain. And we'll also learn the types of CNS trauma and their morphological changes in the brain. And in the end, we also correlate these clinico-pathological findings with the radiologic and histologic features. Cerebrovascular diseases is a disorder caused by pathologic process which involves the blood vessels in the CNS. And there are three types of cerebrovascular diseases, which is one is a ischemic stroke. Ischemia means due to the inadequate blood supply, either due to thrombotic or embolic phenomena. And another one is hemorrhagic stroke, which is due to hypertensive or aneurysmal um, uh, aneurysm in the blood vessels. There will be rupture of the aneurysm, and due to that, there will be hemorrhagic shock. Sorry, I'm really sorry, hemorrhagic stroke. And next is the vascular, due to vascular malformations. This is the image which is differentiating between the ischemic and the hemorrhagic stroke. In the ischemic stroke, there will be a blood clot which blocks the blood vessel. And in the thrombotic stroke, a blood clot forms locally in the brain, which consecutively block the blood flow. Here we can see there is a block, and which is blocking the blood flow in the further vessels. And in the embolic stroke, a blood clot is formed in the body, travels through the bloodstream, and until it reaches the brain, where it blocks the artery, which, that is called an embolic stroke. And next type is the hemorrhagic stroke, which in the vessels intracranial causes intracranial hemorrhage, and the bleeding occurs within the brain. Next is the subarachnoid hemorrhage. In this, the bleed occurs in the subarachnoid space. I'll explain about all of these entities in the later slides. Ischemic stroke pathogenesis. It is caused by the thrombosis, which occurs due to atherosclerosis, ruptured atherosclerotic plaques, or either embolism in the cardiac and carotid arteries. Either due to an ischemic stroke, or also causes by hypoperfusion, and it leads to focal cerebral infarction. Now we'll little bit, there is some introduction about the blood supply of the brain. Blood supply to the brain is by anterior, middle, and posterior cerebral arteries. The anterior cerebral and middle cerebral arteries supplies this part of the brain, and posterior cerebral artery supplies the posterior and posterolateral part of the brain. Middle cerebral artery supplies the temporal lobe, anterolateral, and frontal parietal lobe. Here we can see the internal carotid artery forms this initial segment, and then it goes this continues as a M1 segment, M2, and M3. The internal carotid artery to the middle cerebral artery into M1, M2, and M3 segment. This is the M1 segment, which in the deeper forms the deep penetrating artery and lenticulostriate branches in the deep part of the brain. Then next is the M3 segment. M3 segment supplies the cerebral hemispheres. Here we can see. Now, a morphology of the cerebral infarcts. How the cerebral infarcts look grossly and in the microscopy. Grossly, in 6 to 12 hours, we see that there is a no change. And in 12 to 24 hours, there will be softening and edema. In the edema, we'll see the flat gyri and narrow sulci. And in next 1 to 2 days, there will be blurring of this gray and white junction in the brain grossly. Here, as we can see here, there will be blurring of this gray and white junctions. Then after 1 week, there will be some liquefaction happening due to liquefactive necrosis. This cavity formation will be there. And in 2 to 3 weeks, there will be irregular cavities form, irregular cavity-like area will form, which forms this old infarct. Then in the we come to the microscopy. In 12 to 24 hours, we can see there some red neurons. I'll explain the images step by step. This is first is the normal brain. Here we can see the evenly distributed pink color homogeneous brain matter. Whether like when we come to the edema, how does edema look in the microscopy? When we look into the microscope, when there is a brain edema to the patient, here we can see there is some white spaces in between. It looks like a fluid filled. So this is a edema. It is not that pink than the normal brain. So it is due to the edema. And then we come to the abnormal things. What changes occurs. In 12 to 24 hours, there will be red neurons. These are the red neurons which have eosinophilic cytoplasm and have pycnotic nuclei, as we can see here. And there will definitely also be some inflammation. And since it is acute, only 12 to 24 hours, we'll see many neutrophils here. And in next 1 to 3 days, there will be acute inflammation and ongoing necrosis will be there here. And when we come to 3 to 7 days, there will be microglial infiltration. Microglial infiltration and phagocytosis. If anyone can remember from the last lecture which I have given, there will microglial causes neurophagocytosis. So here when it comes to 3 to 7 days, microglial infiltration will be there. Here we can see there are so many microglial cells which are infiltrating into the ischemic area of the brain and which causes the this phagocytosis. And there will be a lot of lipid debris will be there in this macrophages. Then comes the reactive astrocytosis, capillary infiltration. As if we can remember from the inflammation chapter, first acute inflammation, then it goes to the chronic, then there will be some granulation tissue formation after the chronic inflammation. Similarly, in the brain also, initially we'll see the acute inflammatory cells, then it slowly progresses to the chronic and then macrophages, then comes the granulation tissue. In the granulation tissue, what we can see is the proliferation of the capillaries, some chronic inflammatory cells, like same thing we see here, like reactive astrocytes, capillary proliferation, and some macrophage activity and some chronic inflammation. When we see more than 2 weeks, there will be this cavity formation. As we have also seen in the gross image that there will be a cavity formation. So in microscope, it looks like this. There will be a hollow cavity formation, and here we can see surrounding there is a pink eosinophilic this neural tissue, and surrounding we have this normal brain, and in the center we have this cystic cavity formation due to react, and some there are reactive astrocytes, chronic inflammation will be there. So that is the thing about ischemic stroke. Now we come to the hemorrhagic stroke. When it comes to the causes of the hemorrhagic stroke, it is due to hypertension, amyloid angiopathy, ruptured berry aneurysm, and common sites of these are the basal ganglia, thalamus, pons, and cerebellum. This is the non-contrast enhancing CT scan with acute intracerebral hemorrhage. As we can see, this is the red area is this is the hemorrhage, and the surrounding this green area is the edema, which we see in the CT scan, which we call it as a gray zone. And this is the gross image which is showing the hemorrhage, the pontine hemorrhage. Sorry, I'm really sorry. This is the this thalamus, basal ganglia. Then we come to the subarachnoid hemorrhage. This is the, in subarachnoid hemorrhage, there will be sudden severe headache. As we all know that thunderclap headache will occur in the subarachnoid hemorrhage, worst headache of life. Common causes will be due to rupture of the berry aneurysm, and blood in the, due to this, there will be blood in the subarachnoid space, which causes the vasospasm. And that vasospasm leads to the severe headache. Now we come to the traumatic CNS injuries like concussion, contusion, laceration, etc. So concussion is a mild, reversible traumatic brain injury. In this, there will be just transient loss of consciousness, and either with or without amnesia. As clinicians know this part of the concussion. But in microscopy, what we see in the concussion means like macroscopic brain changes, not much will be there. There will be normal brain, but microscopically we can appreciate some axonal swelling. This is the axons which shows some swelling here. So this we can see in the microscopy. And then we come to the contusion. Contusion is due to the bruising of the brain parenchyma due to the blunt trauma with skull impact. Grossly, we can see this as a wedge-shaped hemorrhagic area. In microscope, we can again see the hemorrhage, necrosis, edema, neutrophils. Same thing as we have seen in the ischemic stroke, we can see in the this contusion. Then we come to the laceration. There is nothing much to it, but it just tearing of the brain tissue due to penetrating trauma, which is associated with a skull fracture or sharp injury, and it often complicated by the hemorrhage and infection. Again, we see the same changes, what we see in the hemorrhage and all. Then we come to the coup and counter coup injuries. Coup injuries at the site of the impact, as we can see here. site. It is at the site of the impact, and counter coup is an injury which on the opposite side of the impact due to the brain rebound of the brain. And this often sees in the falls or in the blow to the when head is in the mobile state and there is a blow to the head, it occurs, this coup and counter coup injuries. I'll explain little thing. And brain injury after brain trauma may occur directly under the site of the impact, which is called coup, and opposite side of the impact, which is counter coup. In the coup injury, there will be direct trauma to the brain, and tearing of the subdural veins can occur, and which causes trauma to the brain base. In the counter coup, there will be damage to the hindbrain, and there will be shearing forces because it is due to the shearing forces through the brain. Then we come to the diffuse axonal injury, which is caused by the angular acceleration. And these common sites are the corpus callosum and brainstem. Here in diffuse axonal injury, we can see the axonal swelling here. Like these axons are got swell, and there are some retraction balls. Here, this axon got swell, and there are some retraction balls. This pink eosinophilic things are the retraction balls, which are called axonal swelling. And we can appreciate this as well with the IHC marker with beta APP IHC. Then next we come to the epidural and subdural hematomas. As most of the clinicians better than me, you know the about epidural and subdural hematomas. Epidural hematomas are due to arterial bleed in the middle meningeal artery, and it causes the lucid interval. And subdural is due to the venous bleed, which is in the bridging veins, and it is a slower onset. The subdural hematomas risk is seen mostly in elderly and trauma-related injuries. Here we can see in the imaging that epidural hematoma between the skull and the dura. And this is the convex inner border, and it is a lens shape. This is the subdural hematoma, which is between the dura and the adenoid matter, and it is a concave. It has concave inner border. Next is the chronic traumatic encephalopathy, which is a progressive neurodegeneration in athletes, which causes memory loss. When there is neurodegeneration, definitely there will be memory loss, and it also causes aggression and Parkinsonism. Pathology of this will be like tau positive neurofibrillary tangles. And here we can see the normal brain. How does it look? And when there is a chronic traumatic encephalopathy, there will be it will be like marked atrophy seen, and the brain parenchyma is all contracted. So this was my presentation for today.
Okay, very good. Thank you very much. Excellent presentation. And we'll ask the audience if there's any comments or questions. Victor, do you have any comments or questions about the presentation?
No, just to make a comment, I have seen several lectures for Dr. Khan. They are really beautiful and very useful to understand not only neuropathology, also neuroanatomy and neurosurgical approach. Thank you, Dr. Khan. Really, really beautiful and useful, your lecture.
Thank you, sir. Thank you so much.
Yeah, Dr. Khan, you know, I'm not a neurosurgeon, but I would imagine that you really have to understand what it is neuropathology, because when you're looking at the brain, you got to recognize healthy tissue or,
Yes.
or
And
variants maybe that are not pathologic, that are kind of like they're not tumorous, they don't look like they've been damaged, but they're different looking, period. Like they have normal variants, right? Is that what they would call them? A normal
yeah,
of the anatomy?
differentiate between normal and abnormal things.
Yeah, like Victor, you've seen lots of brains. I mean, you could probably just look at something and tell if it's
Yeah.
pathologic, right, Victor?
Yes,
Yes,
sir.
of course. I have seen so many, especially traumatic lesions in the Forensic Sciences Institute here in Mexico City. But also in the hospital, we have a neuropathology service department, and we have seen many kind of this disease. But as I told you, I have seen several lectures of Dr. Khan. They are really, really interesting. Thank you so much.
Okay, thanks, Victor.
Thank you.
Yeah, Victor works, this might be interesting to you, Dr. Khan. Victor does a fair amount of work with forensics.
Yes.
So he gets to see a lot of things, a wide variety of things, right, Victor?
Yes, thank you.
Yeah, okay. Someday we got to do a webcast about that forensic lab. You go to the lab, right? You have a forensic lab there in Mexico City, correct?
Yes,
Yeah, maybe we'll take a trip to the lab someday online. Okay, very good. Thank you, Dr. Khan, and we'll see you next week for your next part 3 of the neuropathology of your series.
Yes, sir, definitely.
Okay,
Thank
now
you.
it gives me great pleasure to introduce Victor Hugo Perez Perez. I've been working with Victor for a long time, from the very beginning, about 8-9 years ago. Victor was very open to using this technology. Back then it was Google Hangout, but it evolved to the Google Zoom. And Victor has been a constant presence all over the net. He's probably one of the most recognized neuroanatomists on the planet. And he does a lot of traveling, goes to India, goes to all kinds of countries. And his notoriety or fame has been is attributed to doing a lot of webcasting, and we welcome him today. Hello, Victor. It's all yours.
thank you. Thank you so much, Dr. John Bennett. It's a honor for me to be here. As a matter of fact, I'm not the best, but also I'm not the worst. I just enjoy the anatomy works that I have been doing in Mexico City for almost 35 years. I began doing some injections of brains and spinal cords when I began my medicine career. So I want to show you some of these pictures and these videos, and I know that you are going to enjoy these beautiful pictures of
Can you put it on
brain.
presentation? Can you put it on presentation mode, Victor?
Okay,
Yeah. Try it again.
okay, again.
Okay.
Is it okay?
Yeah. Perfect. Perfect.
Okay, okay. So neuroanatomy is very important to understand surgical procedures. So also vascularity of the brain are very, very important. I had the opportunity to make a research fellow in Detroit, Michigan, about 20, 30, no, 25 years ago. So in those times, I was doing this kind of works. This is an injection of the venous drainage of the external aspect of the brain. This is very important because when you want to make a petrosal approach for some kind of tumors, you need to know how is the venous drainage in order to not to damage the veins because we may have a venous infarction. So let me show you this other video. And all the brains have anatomical variations in their vascular anatomy, especially veins. Veins are they have a great variability in their anatomical aspects. So here we have the lateral aspect of the brain, and injection of the vein of this temporal vein, also known as Labe vein, and it's anastomotic communication with the Sylvian vein and this Trollard vein. So let's go to a view of this video showing the venous drainage of the spinal cord that is also important for spine surgeons. So general neurosurgeon is also involved in this kind of knowledge, in this kind of surgical approach to the spinal cord. What I am showing here are the lumbosacral nerves in this, the posterior spinal vein, and the variation of this venous drainage. So if I displace these nerves, I can see the end of so this lumbosacral nerves and some arteries. They, as you can see, they are very thin, and veins are bigger than this. So let's go to the other. This is the injection of spinal cord. So look at this. This is really beautiful to make this kind of research about the anatomy of the venous drainage of brain and also the spinal cord. And we find several variants of venous drainage. As everybody said, is most important a picture or a video than 1,000 words. So okay, so when we have lesions in the skull base, so we need to know first of all the skull the skull base in the inner and in the outer aspect. And then we should know the vascular anatomy. In this picture, we have the optic nerves, the chiasma, and then the supraclinoid carotid artery that is divided in the anterior cerebral artery and in the middle cerebral artery. And here we can see several thin arteries that are arising from the first segment of the middle cerebral artery. They are known as lenticulostriate arteries. So in this brain was injected with silicon, with red silicon, and also with color blue silicon for veins. And in this other picture, I cut the optic nerves in order to see the infundibulum. This is the infundibulum, hypophysis, pituitary gland, and we can also observe the arachnoid, and some really thin vessels that, for example, this vessel is known as the hypophyseal superior artery. They are very thin and is coming from the supraclinoid carotid artery. In the next, we have the both cavernous sinus beside the pituitary gland, optic nerves, and supraclinoid carotid arteries. So it's also very important to know the sinuses. This is an example of a meningioma, a big or a giant meningioma. So if you want to do the best surgical approach, this is very important to know how to go to resect this kind of tumors. So in this case, it's very important to respect the vessels that are surrounding the meningio, this giant meningioma, for avoiding an infarct or a transoperatory hemorrhage. So in this surgery, I resected all the tumor. Here we have a remnant in this pterional approach to go for this tumor. So this is a very small tumor. I resected all, and also this remnant of the tumor. So here we have another picture to show the pituitary gland. Here we have the adenohypophysis and then the neurohypophysis, and the irrigation that is coming from the intracavernous carotid artery. I remove the dura mater in order to see this anatomical preparation. Here we have the supraclinoid carotid arteries and intracavernous carotid arteries, and arteries that are coming from this artery. So this is the posterior aspect of this pituitary gland. This is a superior view, and we can see the anterior aspect. So here we have the both optic nerves, supraclinoid carotid arteries, the arteries coming from intracavernous carotid artery going to the pituitary gland. And here we have the third cranial nerves. In the next, we can see the removing of all the tumor that I showed you in the last slides. And sometimes we should make a big approach in order to remove big tumors. This is a challenge for a skull-based surgeon, but also for neurosurgeons. So in the actual time nowadays, we have much better technology to go for this kind of tumors. But not in all the countries we have, especially in the official institutions, not all the hospitals have a neuronavigator, neuroendoscopy, and every kind of technology. So we should be prepared to make the surgery related with the technology we could have. So in here we did a big craniotomy. This is the frontal bone, and this is the nasal bone for removing a big tumor. The tumor was in the frontal aspect of the skull, but also into the nose. That's the reason we remove this all of this bone. So here we have in the right picture the removing of this lesion. Here we have another tumor, a big tumor. These tumors are related with some arteries. So if we should know neuroanatomy to remove these tumors. Here we have an anterior floor meningioma, but as you can see, this tumor is going to the pituitary gland. If you make a standard approach, a common approach by frontal approach, look at what could happen in this. So here we have a line to go to this tumor, and maybe in this way you can remove this part of tumor. But sometimes we do an osteotomy, fronto-orbito-ethmoidal osteotomy, in order to go to the base of this tumor. Here we have the preoperative and the postoperative. This is a picture about this surgery. And other times we have malignant lesions that affect the orbit, all the orbit, the eye, and in this kind of lesions, this requires a multidisciplinary approach. In this case, we make the surgery with a neck surgeon. For doing this kind of surgery, we need a big preparation, a big exercise, doing workshops in skull base anatomy, and also in doing dissection. This is a picture about a workshop that we have been doing in the Forensic Sciences Institute in Mexico City. Sometimes we could use microscope to do these studies. So here we have some pictures about the approach of this surgery. As you see, we remove the eye, all the orbit, and this is the lateral aspect of the face. So in this, we have also the jugular vein. This approach was made by the neck surgeon, but we as a brain surgeon protect the brain in this case. Other times, we cannot do something for the patient because of the extension of these lesions. This is a carcinoma of the face, and in this case, we will not operate because the extension of this lesion. This is a picture in the superior aspect of the brain to show the superior sagittal sinus, and some lacunae are the largest, which are largest and most constant in the parietal and posterior frontal regions. So when there is a tumor, for example, a meningioma in this place, we should be very careful in order to avoid damage these veins. If you damage some of these veins, you are going to produce an hemorrhagic venous infarction in this place. So we need to go very careful. For example, in this case, this patient was almost 22, 23 years ago, 23 years old, and we did a resection of this tumor. The tumor was resected, removing also or closing the superior sagittal sinus because it was occluded, it was closed because of the extension of this big tumor. This sagittal sinus drains into the transverse sinuses and goes to the sigmoid sinus and then to the jugular vein. Here we have another pictures about these tumors. This picture was taken several months after the surgery, and in the region when we close the superior sagittal sinus, here we have a small remnant. This could be treated again with a surgical procedure or other way to treat it. Here we have the lateral aspect of the brain showing the vein of Labé and frontal vein draining to the transverse sinuses. And here in color red, the branches of the middle cerebral artery. Other pictures about this case, and this straight sinus originates. This is the straight sinus originates behind the splenium of the corpus callosum, at the union of the inferior sagittal sinus and the great vein. So this is the patient who was treated with this surgical approach. And here before the surgery, he had vision problems, and after the surgery, he recovered some functions. This is about the sinus vein. This is in the anterior aspect, in the anterior part of the sagittal sinus. So some other pictures about this venous drainage. This is the vein of Lavey. This vein of Lavey is very important because if you have to make a petrosal approach, you have to respect this venous drainage, especially if this vein do not have a good anastomosis with other big veins. If this vein of Lavey do not have a good anastomosis and you damage this vein in the surgical procedure, you can cause a big infarction of the temporal bone. This is really a big problem in the transoperative course of this surgical procedure. So here we have a dissection in the lateral aspect of this skull base, and this is for a better understanding of the skull base and some variations in the venous drainage in the petrosal part of the skull base. Here I am doing a mastoidectomy. I am doing here this mastoidectomy with I am drilling this region of the skull base of the petrosal bone. So if you want to make this surgical procedure in a person, in the patient, of course, you should make several dissections of the cadaver specimen to understand the anatomy of the bone and for avoiding damage of especially the sigmoid sinuses. And here, this is I am doing this mastoidectomy, but it's very important to make exercise, to make dissections, to make this kind of surgical procedures in specimens. So here I am doing this approach, a big approach, lateral approach of the skull. Here we have the temporal bone, and we have to respect these veins in the lateral aspect of the brain. So this is another aspect of this surgery. In this case, I am closing the superior petrosal sinus. Why I am doing this? This is because I need a better view to resect the petrosal tumors. So this is also a beautiful picture about axial cut, axial view of the brain. In here we can see the anterior cerebral arteries, the middle cerebral artery, the temporal bone, the mesencephalon, the peduncles, and if I make a mulligan staining, this is this is a really beautiful staining to differentiate the cortical substance and the white matter tracts on the brain. Look what happened if we do this staining. In this after doing this mulligan staining, we could observe in blue the cortical substance, the cortex, and in color white the white substance. So this is another picture to see this. Really beautiful, this kind of staining to understand the tracts of the brain stem, as you can see in here. For example, in here we have the medial lemniscus. Here we have the red nuclei. In this we have the globose nucleus, and then the superior cerebellar peduncle. So this is the last picture. Thank you so much for your kind invitation, John Bennett. Thank you so much.
Victor, thank you very much. Another great presentation. I received a comment from Ada Bhatti, a neurosurgeon that we work with a lot, and he said great videos. He didn't come in here, but anyways, any comments or Ata, you're here? Okay, great. Go ahead, Ata. Oh, okay. Let me see here. Maybe I got you. I gotta admit you. Just give me a second. Okay. As soon as he comes in the panel, he'll be able to ask a question. Go ahead, Ata. Go ahead, Ata.
Yeah, thank you so much. Thank you so much, Professor Victor. Excellent, excellent presentation, and a lot of dynamic understanding about Venus. So it's one of the most important to learn, as you mentioned, doing dissection, understanding between the deep, superficial, and petrosal system. And one of the area which I would like to highlight is, can you hear me?
Yes. Can you put your
Okay.
picture, your camera on, Ata?
Sure. Okay, I will. Sorry, it will open in a while. So let me just continue with my comments. So one of the Venus video which you showed regarding the lower lumbosacral region, so it was brilliantly demonstrating the conus medullaris cardiac region, and the basket of vascular connection, which are very essential for neurosurgeons or neurointerventional people to understand before they do any movement. For example, this is the area very common for neural tube defects, the stomatomias, the lipomyelomangioceles, the AVM of these regions are notoriously involving and sharing the blood supply. So the venous and as well as arterial anatomy is beautifully described by the samples. I have never seen that clarity before. So we do see on the angiographic views, the tortuosities of the phylum terminal was visible. So that's one region you could help to identify the cauda equina angulation, where they join the conus and then they drain into the iliac system of vessels or spinal system of vessels. So anything you do below that at the phylum terminal level, for example, in tethering of cord and you want to detether. So precisely knowing this will even make you not dependent on neurophysiological monitoring. This is one implication. So when you work on lower lumbar tumors, like in ependymomas are common in this region. So when you do myelotomies, so it's very crucial to know that unlike to anterior, where the anterior spinal artery makes the one vessel and grow down into the anterior anterior fissure. So in the posterior, you do have a network, capillary network. So you don't have the two stems of posterior vertebral arteries. So you have a similar pattern of variable venous anatomy. So what we call the basket is beautifully demonstrated in those samples by Professor Victor Hugo, and it's amazing and it gives a very clarity. So going back to the different approaches of the brain and showing those, I just want to mention for the curiosity of our juniors that the chronic cerebral venous insufficiency is an area of research and very popular amongst multiple sclerosis researchers, and also for neurosurgeons like Professor Hugo already mentioned. To save the venous system is to save the patient, and you see a lot of neurosurgeons telling the first post-operative day or few hours after the surgeries that they did the beautiful job, the patient is out from the anesthesia, and on day second, they got a call from ICU that patient had bled. So this is the common scenario when you jeopardize the venous system, and it's not a preventable complication if we understand the venous anatomy, and we do work on that preoperatively. So it's a wonderful area an essential area for us as clinicians to know. Thank you so much, Professor Victor.
Thank you, Professor Atta. Thank you so much. I have a research about arteries of the spinal cord. And we have found a special artery that was described almost 50 years ago. That is a posterior great spinal artery. But I think we can talk about this in the next session, Dr. John Bennett, to show the anatomy, vascular anatomy of the spinal cord. That is really interesting. Thank you so much for your kind comment, Dr. Atta. Thank you,
if
Dr.
you have
Yash.
time, I can ask one question also, if there is time. Or we can continue with the next presentation.
Yeah, we'll do it, Victor. That's great. I know you've done a lot of work on the spine lately, and one of the things I want to point out to everyone is that when I saw Victor's latex injection, I was fascinated. And I don't think many neuroanatomists do that, Victor, correct? Many neuroanatomists inject latex to delineate the vessels in the brain?
Yes, there are several physicians that are doing this kind of injections, but not so much.
It's
A
time
few,
consuming, right?
a few, yes, and they are doing also a really nice job.
Okay,
Thank you, Dr. John.
it's time consuming, right, Victor? It takes a lot of time to
Of
inject.
course, especially when you are going to dissect and to take statistical data is consuming time.
But
Right.
Victor, your specimens were looking very fresh.
Yes, that's the secret. That's the secret.
Yes, yes. It was
Yes,
depicting the accurate anatomy.
yes,
Very
yes.
reliable.
Yes, because if you work with a specimen fixed with formaldehyde, is almost impossible to make a good dissection. Almost impossible.
And
Yes.
dissecting near the veins is very challenging compared to arteries when the walls are high.
Yes.
So it's
Yes.
real
Yes.
test of
Yes. Yes.
microvascular skills.
Yes. It's not easy. Sometimes you are successful. Sometimes not.
Yes.
Okay, very
Thank you,
good.
sir.
Perfect.
Okay, I'm going to put a link to all the videos that Victor's done with Neurosurgical TV. We have hundreds of them, and I'm going to put that in the chat. Okay, and we look forward to next week having neuroanatomy of the spine, an area where Victor has done a lot of work in the last year or two. So thank you, Victor. Okay,
Thank you.
why don't we move to Yash Pal? Yash is between, he just graduated from medical school, University of Nis in Serbia, and I believe now he's in Mumbai, and perhaps he could correct me. But welcome,
sir.
Yash. Can you please, a few minutes of introduction, then lead on to your webcast, please?
Thank you so much for the kind introduction, sir. So my name is Dr. Yash. I graduated this year, 2025. I was formerly in Ukraine, and then I took a transfer to Serbia, and now I'm glad to be back home. So from here, I'll be preparing for my future in the field of surgery, specifically neurosurgery, sir. And
Very
with
good.
all of your permission, I have got a presentation ready on hydrocephalus, diagnosis and management in neurosurgery. And if you all allow me, I'd like to begin presenting it.
Great.
Thank you, sir. So right here, as you can see, this is going to be my presentation, sir.
Yes.
And over
Perfect.
here, I'd like to talk to you about how hydrocephalus is being dealt with in the field of neurosurgery. So first of all, here's a brief introduction, sir. Hydrocephalus is often referred to as what we call water on the brain, and is one of the most common and challenging conditions managed by pediatric neurosurgeons, to be very specific. And it's a very super specialty, extremely niche, and hydrocephalus is something which is very much dealt by them. It is a dynamic condition which is characterized by imbalance between the production and absorption of cerebrospinal fluid, leading to its accumulation within the brain's ventricular system. So, that being said, let's move on to the next part, which is about the physiology of CSF. We know that it's going to be an overflowing of it. However, we need to understand the normal physiology of how we can deal with it. To this side, as you can see, I've got an image, and over here, I have a particular text related to it too. So you can see I've got in the image different correct labels marked in for a better understanding of it. Choroid plexus, cerebral aqueduct, foramen Luschka, foramen magneti, and central canal. Now what happens is CSF production, which is a colorless fluid, is produced primarily in the choroid plexus. Now, with the CSF flow there is a precise pathway that it follows. It originates from the lateral ventricles, flows through the foramen of Monro into the third ventricle, and passes through the narrow cerebral aqueduct, which is also the cerebral aqueduct of Sylvius, enters the fourth ventricle from there, and exits into the subarachnoid space surrounding the brain and spinal cord. Then there is a reabsorption also happening in the second last step. So this reabsorption, how it deals with is it is being back into the bloodstream, where primarily through specialized structures called arachnoid granulations. Arachnoid granulation is the one which is the key structure responsible for the reabsorption. Now here's some classification on hydrocephalus after the pathway disruption occurs. First one is going to be communicating, and the next one is going to be non-communicating. I'll talk about communicating first. The mechanism of this type is there is no physical obstruction within the ventricular system itself. But the problem arises with the impaired CSF reabsorption. CSF reabsorption, like I said, it's going to be via the structures of arachnoid granulations. So over here, some common examples I'd like to present is going to be post-meningitic or post-hemorrhagic. Blood products from an intraventricular or subarachnoid hemorrhage can similarly block the reabsorption of pathways. And I have got the clogging of arachnoid granulation, which will be post-meningitic. Next, coming to the second part, which is going to be non-communicating or obstructive hydrocephalus. The mechanism of this is the form of physical blockade, or rather the obstruction, somewhere along the narrow CSF pathways within the ventricular system. Common causes in pediatrics is going to be aqueductal stenosis, a narrowing of cerebral aqueduct between the third and fourth ventricles. Now I've got an image of 10 possible causes, and over here on the text, I have got etiology in pediatrics. So etiology says we have got congenital as well as acquired causes. Congenital being aqueductal stenosis, neural tube defects, Dandy-Walker malformation, genetic syndromes, and acquired causes being intraventricular hemorrhage, infections, and tumors. Possible causes of hydrocephalus, which is commonly noted, is going to be genetic abnormalities, developmental disorders, infections during pregnancy like rubella, complications of premature birth, including intraventricular hemorrhage, meningitis, tumors, head injuries, subarachnoid hemorrhage, and bleeding, and complications following brain surgery. Then when we talk about clinical features, is how the patient or the child is presented in the department of OPD or ER. Bulging fontanelle is seen, and rapid head circumference growth is also noted. There is one sign which is very critical to noting out when we look at the eyes of the patient or the child, in fact. It's called the sunset eye sign. A downward deviation of the eyes where the sclera is visible above the iris caused by pressure on the midbrain tectum. This is also known as Perinaud syndrome. Irritability is also noted, and poor feeding is known. Infant may be lethargic, difficult to console, and have difficulty feeding. Towards this side, as you can see, I have an image ready. It has been showing us the brain and ventricles of the normal child and the brain and ventricles of a big child with hydrocephalus, one on the top and one on the bottom, which is right next to my shoulder. Ventricles filled with extra fluid are shown to be enlarged, and the head size also enlarges with it. Older children with few cranial sutures will have different kind of clinical presentations. They will have headache, nausea, vomiting, gait disturbances, papillary edemas, cognitive decline, and last but not least, lethargy. Then when we come to diagnosis, a biggest key diagnosis which can be used is going to be neuroimaging modalities. Cranial ultrasound, CT scan, MRI are all very helpful. MRI being the gold standard in this case. Key imaging signs to note is going to be ventriculomegaly, which is a disproportionate enlargement of the ventricles relative to the cortical sulci. Periventricular edema on T2 weighted MRI or as low density on CT appears as halo around the ventricles, representing transependymal flow to the CSF into the brain tissue due to high pressure. And the last key imaging sign which will be noted is going to be ballooning of the third ventricle. After that, we have got differential diagnosis, which is very critical when it comes to a pediatric case. The 4 differential diagnosis is going to be benign enlargement of subarachnoid space, which is a self-limiting condition, cerebral atrophy, which is also hydrocephalus ex vacui, which is actually loss of brain tissue. From hypoxic ischemic injury, it can happen. Tumors with mass effect, which is a large tumor that can cause symptoms of increased intracranial pressure without necessarily being hydrocephalus, although many tumors do both. And the last one being pseudotumor cerebri, which is idiopathic intracranial hypertension, often seen in overweight children and patients having high signs of high ICP, which is headache and papillary edema. Here is the pathway of different mechanisms how we can interject or intervene to solve this case. Towards the top, we have got a way we can intervene into the brain vascular system via the blood-brain barrier. To the side of it, we have got glial-mediated lymphatic system, which is responsible for CSF exchange. Right to the bottom, we have got convergent mechanisms involving dampen inflammation, regulate CSF production, and repair of fibrosis, and a lot more. Then onto this end, we can see we have got choroid plexus. Now, what happens in choroid plexus is the epithelial cells, stromal cells, and microglia are the ones that are affected. Then last but not least, we've got ependymal lining, which is of the brain cerebrospinal fluid barrier. And its inflammation causes SVZ damage, astrogliosis, and hemorrhage. There is also certain complications to be kept in mind when certain cases are observed. Towards the end, that end of the slide, you can see an image place, which is of a proximal ventricular catheter and also a one-way valve. What happens is VP shunts are mechanical devices prone to failure and complications throughout the patient's life. However, infections is one of the risks which is still present even after shunt has been placed in the most sterile fashion. Obstruction or blockade, over drainage, mechanical failure, and multiple revisions are also some of the complications noted in shunt. Then I would like to move on to the next slide, which is of how we can indicate the treatment of this. We have got a third ventriculostomy, ETV, and we got ventricular peritoneal shunt. Indication is going to be primary obstructive hydrocephalus for ETV, and for VP it's going to be communicating and obstructive hydrocephalus. Invasiveness for ETV is minimally invasive, whereas for VP shunt it's more invasive. Complication is including risk of bleeding for ETV, whereas there's high rates of infection, obstruction, and mechanical failure in ventricular peritoneal shunt. On long-term basis, if we calculate the difference, there's going to be no implanted hardware under ETV. However, there's going to be a lifelong hardware follow-up for ventricular peritoneal shunt. Special case is where we have got post-intraventricular hemorrhage hydrocephalus in preterms, which is a common cause in NICU noted, and it's critical need for early recognition, progressive ventricular dilation, and last point is going to be role of temporary measures, which also includes serial ventricular taps, subcutaneous ventricular reservoir, and external ventricular drain, which is EVD in abbreviation. And then my next slide is going to be about prognosis. A long-term outlook for a child, we have to make sure that the underlying etiology of the hydrocephalus is what it heavily depends on. And impact of early intervention is going to be the unquestionably effective surgical intervention. Necessity of long-term follow-up in these children are from a multidisciplinary team. It's not just neurosurgery, it's going to be neurology, neuropsychology, and rehabilitation specialists. We will have to also seek a pediatric consult based on the development of the child, like cognitive, motor, developmental challenges. So. And with this, I'd like to conclude my presentation over here by showing summary. A manageable condition is what a hydrocephalus is. Towards the end of the image, you can see a clinical presentation of a child with hydrocephalus, and the importance of early action is to be noted, and a multidisciplinary approach is there. Thank you so much. This has been Dr. Yash.
Okay, very good. Very good, Yash. Any comments or questions from the audience? Okay, we're running a little short on time, Yash. I'm sorry we can't have a lot more comments and stuff because it's such an important topic. I hear about it all the time. So next week we have Chandra Deopujari, a big neurosurgeon from India, and you mentioned pediatric neurosurgery. He did a 2-week, he did a webinar for us on pediatric neurosurgery for India. He's going to be here, as well as Dr. Bushnan from India. He's an artificial intelligence neurosurgeon, and he's going to be giving lectures on what a medical student needs to focus on as far as AI and neurosurgery. So we will see you next week, and thanks everyone for attending. Thanks, Victor. Thanks, Atta. Thanks, Yas, for a great presentation. And thanks, Dr. Khan.
Thank you, sir.
Bye-bye.
Goodbye.
Thanks.
Okay, Victor.